Well, welcome to this new series of videos where we're looking at multiple choice questions. Now, you could take this fairly seriously if you want to, that's fine. But if you just like doing questions for a bit of fun, that's fine as well. So we'll have one slide with the question. So you can freeze frame on that and take this quite seriously if you like. They're all genuine questions that I've constructed, as you can see, on the topic of wound healing. Or you can just skip through to the slide immediately afterwards, where you'll get the answer. So here's the first question. Notice that there are two correct answers that you need to pick out. So you can freeze frame at this point to give you time to consider it. So healing by primary intention is when the edges of the wound are together and can heal directly into each other. And this is always the preferred method of wound healing if it's feasible. So this will give us fairly rapid healing, as opposed to healing by secondary intention, which can be a slow process. And also, because the edges of the wound are together, hopefully there'll be intact skin around the edges where the wound is approximated. So that means that the area of the wound that is actually a wound, because the two edges of the wound are brought together, will be fairly small. And that means that there'll be minimization of the amount of scar tissue. B is wrong. B says reduce risk of any foreign bodies being left in the wound. There's not a reduced risk. If anything, there's an increased risk. So before we close a wound using primary intention, we must make sure there are no foreign bodies in it. So B is absolutely wrong, because there is somewhat of an increased risk if the wound is not explored or if the wound is not cleaned properly. Interferon is related to a chemical that cells will release when there's a viral infection, so it's not really relevant. And decreased risk of anaerobic infection is actually wrong as well, because if the wound is not properly cleaned and we close the surface of the wound, then there is the risk that there'll be anaerobic organisms left within the wound that can then multiply and divide, potentially causing anaerobic infection. So this shows the importance of assessing wounds properly before we close them, to make sure that there's not any contraindications, such as foreign bodies being left in the wound, or the potential for anaerobic infection to develop in the wound. So the last question was about primary intention. This is healing by secondary intention. And notice here that there's actually three correct answers for you to pick out. So here we're thinking about a wound healing by secondary intention, when the edges of the wound are not approximated and the wound is left open to heal by granulation, often with us packing the wound on a regular basis. And this does mean that there is a reduced risk of anaerobic infection, because there'll be no anaerobic organisms sealed within the wound where the levels of oxygen can start to reduce. So if there is infection, it'll be left exposed to the oxygen on the surface of the body. And it also means, because we're probably going to be repacking and cleaning this wound on a regular basis for a period of time, we can physically wash any anaerobic infections away. So it's wrong to say there's an increased risk of anaerobic infection. C is correct. Wound healing is usually a slow process. So in secondary healing, we have to wait for the formation of granulation tissue, and the wound area can be large and it's going to take time to heal. Whereas with primary intention, because the edges of the wound are healing directly into each other, that can be a rapid process. So C is true. Wound healing is usually a slow process. D, which says wound healing is usually fairly rapid, is clearly wrong. That's referring to primary intention. Now, E is correct. Cosmetic results are often poor, because when we get a lot of granulation tissue, some of that can end up as scar tissue. So we're going to get more fibrous scar tissue present after the wound is healed. So cosmetic results are often not as good as with healing with primary intention. And that makes F wrong, which says cosmetic results are usually good. Well, we've just said that that is not true. 3 of these answers would suggest that selecting a primary healing method, that using primary intention, is appropriate in a particular situation. What are those 3 answers? So before we treat any wound, we have to decide what sort of wound healing strategy we're going to employ. And if possible, we want to employ primary intention, where the edges of the wound heal directly into each other. Now, if there's significant tissue loss, it won't be possible to approximate the edges of the wound. So if there's significant tissue loss, healing by primary intention is not going to be feasible. And if granulation tissue is already present, that means that the wound is presented to us late and healing by secondary intention has already begun. And that also means that the wound is going to be colonized by microorganisms. So all wounds that are more than a few hours old, certainly wounds that are a few days old, are going to be colonized by microorganisms. Not necessarily infected. They won't necessarily be the clinical features of inflammation, the heat, pain, redness, swelling, the loss of function, the exudate, the change in wound appearance, the smell. That not necessarily those features, but there will be bacteria there. So if we're going to choose primary healing, ideally we want there to be little tissue loss, so the edges of the wound can be approximated. We want the wound to be clean, so we're not closing in any foreign bodies or potential infective organisms. And it's necessary for the edges of the wound to be approximated, otherwise the 2 edges of the wound aren't going to heal into each other by primary intention. Well, the powers of the body to heal itself are impressive, but it has great limitations. So which of the following tissues will not mitotically regenerate? Where will there not be mitosis, which replaces new cells for old? Now notice this question requires 2 answers, and it's asking which of the following tissues will not mitotically regenerate. In other words, if a tissue is damaged, will there be mitosis to replace the damaged cells with new cells? And this is important if a tissue is going to regenerate. So for regeneration of the tissue, we need ongoing mitosis that will regenerate the tissue by replacing the cells that have been lost. In tissues where this is not possible, there can only be healing by fibrosis and scar tissue formation. So in the skin, if we think about the lower layers of the epidermis, there are keratinocyte stem cells, and they're capable of dividing throughout life. Their numbers will decrease with age, but they will carry on dividing. So the skin will mitotically regenerate. That's good because it means it can heal without a scar under certain circumstances. Bone tissue is capable of ongoing mitosis. Bone is a very vibrant, living, metabolically active tissue with a good blood supply. And the cells in the bone, the osteoblasts, will divide and regenerate the bone. Likewise with connective tissue. If there's injury to a tissue, that will actually stimulate fibroblasts to divide mitotically. So in a healing wound, there's going to be an increased number of fibroblasts. And the fibroblasts will produce the connective tissues, the collagen, the elastic tissues, and indeed the matrix, the ground substance. But muscles do not have significant powers of mitotic regeneration. So, for example, if someone has a myocardial infarction and myocardial muscle cells die, those cells won't be replaced. That's why it's so important to treat these conditions very quickly, because time is muscle. But if there's damage to skeletal muscles, again, the muscle cells won't mitotically be replaced, at least not in any significant numbers. Now, when you exercise, muscles will get bigger, but that's because the muscle cells will hypertrophy. The individual cells will get bigger, but there won't be an increase in the number of the cells themselves. And likewise, nervous tissue doesn't regenerate. Now, the cells in the spinal cord don't regenerate. The cells in the cortex don't regenerate. That's why if someone has a stroke, they can be left with permanent neurological deficit. Now, 10, 20 years ago, we might have said that neurons in the brain are incapable of mitosis altogether. We now know that is not entirely true. Especially in the inner parts of the brain, in the medullary parts, there is some slow ongoing mitosis throughout life, but not really enough to heal any significant injury. And the cortex is not a good regenerator. Now, peripheral nerves, the nerve fibres, the axons and the dendrites, will regenerate very slowly as long as their cell bodies are intact. And typically we say that nerve fibres will regenerate at approximately the rate of 1 millimetre per month. That's just over a centimetre per year. So they will grow, but very slowly. So the basic answer to the question is muscles and nervous tissue do not mitotically regenerate in a way which is effective to facilitate wound healing by regeneration. Well, if you haven't yet memorised the clinical features of inflammation, this might be the stimulus that you need to do so. The clinical features of inflammation, of course, are heat, pain, redness, swelling, loss of function. Now, we do want mitosis in wound healing, but it's not one of the clinical features of inflammation. And meiosis, you might remember, is reduction cell division that only takes place in the gametes, in the ovaries and the testes. So in mitosis, the parent cell, the mother cell with 46 chromosomes, gives rise to 2 daughter cells, each with 46 chromosomes. In meiosis, a haploid cell is generated, where a stem cell with 46 chromosomes will divide via meiosis to produce 2 cells, 2 daughter cells, each with 23 chromosomes, giving rise to ova and sperm. So heat, pain, redness, swelling, the classical clinical features of inflammation that we always have to look out for. Well, we only need one correct answer here, and this is to test if we know the stages of the wound healing process in the correct order. Well, there's only one correct answer here. First, there is an inflammatory stage. That's good because inflammation is the first necessary stage of the healing process. Increasing the blood supply, increasing the oxygen supply, increasing the delivery of nutrients, facilitating the transference of white blood cells, neutrophils for example, from the blood into the wound tissue area where they can phagocytose potentially infective bacteria and indeed, as we'll see in the destructive phase, phagocytose dead and damaged tissue cells. So the inflammatory stage can overlap with the destructive phase. And in the destructive phase, there's going to be phagocytosis, first by the neutrophils, later on monocytes will arrive, migrate into the tissues where they become macrophages. Macrophage, the big eaters. And they will eat the bacterial infection and they will destroy phagocytically any non-viable areas of tissue which have been damaged by the injury, because we don't want necrotic tissue left in the wound, because that's going to be an excellent bacterial habitat and substrate. And then, as well as the white cells migrating into the wound, there's going to be other things migrating into the wound, such as the fibroblasts, which are going to regenerate the connective tissue. So inflammation first, destructive migratory second, proliferation, where all the healing cells proliferate. So there'll be increased numbers of fibroblasts. There might be re-epithelialization if the wound is involving the surface of the skin. There will need to be proliferation of the vascular endothelial cells as new capillary loops grow into the healing tissue. in the process of angiogenesis or angioneogenesis. And then fourthly, there's a maturational stage, where the amount of fibrous tissue is going to be reduced, hopefully being replaced by healthy adjacent tissues. And that's why we say to patients that your scars will get smaller and fade, because there's going to be a maturation phase in wound healing. So an understanding of these 4 stages, if we think of it in these terms, is good for facilitating our understanding of the whole wound healing process. Well, when a tissue is injured, it's going to release inflammatory mediators. And one of these inflammatory mediators is histamine. It is stored in mast cells, which derive from basophils in the blood, but the mast cells just live in the tissues. And then when a tissue is insulted, the mast cells can release the histamine, which is one of the inflammatory mediators. But do you know what it does? Well, in inflammation, there's going to be vasodilation, because we want there to be a localized hyperemia, increasing the blood supply, increasing the oxygen delivery, increasing the delivery of all the substrates and building blocks that are necessary for the healing process. Taking more oxygen, taking more glucose, so because wound healing is a very energy demanding process. And there's increased capillary permeability as well. That lets out the fibrinogen and it allows the white cells out to perform their important phagocytic functions. So what we don't want in inflammation is vasoconstriction, because that would reduce the blood supply. That's exactly what we don't want. And we don't want decreased capillary permeability, because that would reduce the ability of nutrients to get to the wound. That would reduce the ability of the white cells to enter the tissues where they can be phagocytic. Now the last one, localized analgesia. Actually, inflammatory mediators are going to sensitize local nociceptors and cause increased sensitivity to pain. So there's not going to be localized analgesia, because an means without. So analgesia means without pain, and the exact opposite to that happens. So that leaves us vasodilation and increased capillary permeability as the correct answers. Wound healing is a very cellular process. Lots of cells are involved. But do you know which cells are phagocytic? Which cells are capable of cell eating bacteria, eating dead necrosed tissue cells and digesting them within their cytoplasm? So we notice that this question says, which of the following cell types are not phagocytic? So monocytes migrate into the tissues and become macrophages. They are the big eaters. They are very phagocytic. And likewise, neutrophils are much smaller, but they're also very phagocytic cells. Now, macrophages is a descriptive term for monocytes. Macro, big, phages, to eat. So the monocytes are actually macrophages. And the converse, or the contrast of that, are the neutrophils, which are much smaller cells. So they're sometimes called the small eaters or microphages. So really, monocytes are macrophages and neutrophils are microphages. So the one that is not phagocytic, the lymphocyte category, and the T killer lymphocytes are not phagocytic. Now, T killer lymphocytes are very good. They can recognize and destroy malignant cells, for example. And if a cell is infected by a virus, they can recognize the virally infected cell and are quite capable of destroying the whole cell. But they kill via a different mechanism. They are not phagocytic. They actually work by depositing noxious chemicals on the surface of the cell to kill the cell that's infected or malignant. Now, fibroblasts are essential to the process of wound healing, but do you know what they do? Now, fibroblasts, a blast cell will produce something like an osteoblast produces bone. A fibroblast produces fibrous tissue. So it will produce fibrous tissue. So it can produce collagens. it can produce elastic tissues. And the fibroblast will also produce the ground substance, the essential matrix, which is in between the capillaries and the other components of the tissue. Now, fibroblasts will actually contract in a mature wound. Mature fibroblasts become contractile and they'll make the wound smaller. They work like a very slow motion smooth muscle to contract wounds, but they don't actually break down the scar tissue. They don't prevent multiplication of bacteria. They don't promote cell division in local tissue cells. That's the macrophages that do that. The macrophages in the wound produce all sorts of cytokine growth factors. A cytokine is a chemical produced by one cell that will stimulate physiological activity in another cell. So the macrophages will produce cytokines which coordinate the wound healing process by promoting cell division in local tissue cells. So it's the macrophages, not the fibroblasts. And the fibroblasts don't recognise non-self organisms. That's much more the role of the lymphocytes. The lymphocytes are able to recognise non-self organisms and facilitate the process of antibody, that is immunoglobulin formation, the formation of the immune proteins. So the main thing the fibroblasts do is produce useful things like fibrous tissue. Now, we need to advise patients of things that will promote wound healing and warn them against things that will adversely affect the wound healing process. And you might guess that smoking is not good for wound healing. It's interesting that very few people, or fewer people in the UK smoke now. I think the percentage of smokers in the UK is down to below 20%. But what's tragic is that the amount of people smoking in poorer countries is increasing. But wherever we live, we need to advise our people not to smoke, especially when their wounds are healing. But why is smoking bad for wound healing? So we're asked for 3 reasons, 3 rationales why smoking adversely affects wound healing. Well, it's not going to reduce protein catabolism. Now, catabolism is a metabolic reaction where big molecules are broken down into smaller molecules. So that's not going to be relevant. The converse of catabolism is an anabolic process, anabolism, where small molecules are built up into bigger molecules, but that's not relevant here. And the smoking won't increase the amount of oxyhemoglobin in the blood either. But what it will do is increase the amount of carboxyhemoglobin in the blood. Now, when carbon monoxide forms a bond with hemoglobin, that bond is really quite stable, and the compound that is formed is called carboxyhemoglobin. And that carbon monoxide molecule can dominate the hemoglobin molecule, occupying and filling its carrier site for hours or days, preventing that hemoglobin molecule from carrying oxygen. So the more you smoke, the more carboxyhemoglobin there is in the blood, the lower the oxygen carrying capacity of the blood. And because wound healing is a very metabolically active process, it needs lots of oxygen to facilitate the generation of energy in a wound. So anything that reduces the oxygen carrying capacity of the blood is going to adversely affect wound healing. Smoking also interferes with normal vitamin C metabolism. Now, vitamin C is essential for collagen formation. So for wounds to heal, we need to generate some collagen, the fibrous connective tissue collagen. And smoking reduces the activity of vitamin C, increases the excretion of vitamin C, therefore it lowers the amount of physiological available vitamin C. And that's going to restrict collagen synthesis. It will be harder for the body to make collagen, and it will be able to make less collagen. And that will adversely affect the healing process. Nicotine is also a direct vasoconstricting molecule. So if it vasoconstricts, that's going to close down the blood vessels, and that's going to reduce wound perfusion. there'll be less blood going to the wound. The wound won't be as warm. The wound won't be as oxygenated. The wound will not be receiving the building blocks, the proteins and the fatty acids that it needs to generate the new tissues. And the metabolizing wound won't be able to get rid of its waste products such as carbon dioxide or lactic acid or nitrogen molecules as effectively. So the wound can be hypoxic, malnourished, and left to stew in its own toxins, all of which are bad for wound healing. So 3 really good reasons there not to smoke, and advise our patients not to smoke, to prevent this adverse effect on wound healing.